Abstracts from DDW. I'd like to welcome Dr. Berkeley Limketkai from UCLA, from our Inflammatory Bowel Disease Center, and he will take us through, and then we'll have questions at the end. Thank you.
Good morning, everyone, and thank you very much, Eric, and the organizers for this opportunity to highlight some of the notable presentations from the recent DDW on inflammatory bowel diseases. So in a brief outline, I'll actually review the impact of nutrition support on post-surgical outcomes, recognize the effects of corticosteroid use in pregnancy, evaluate the prognostic value of calprotectin for ulcerative colitis, as well as understand the role of the Mediterranean diet versus the specific carbohydrate diet for Crohn's disease. So as you can see, in contrast to Tina, who had focused more on the controlled clinical trials, I will focus more on the studies that were using other study designs. So let's begin. This is a study that was actually performed here at UCLA. It was studying the impact of perioperative nutrition support on patients undergoing major inflammatory bowel disease surgery. As background, we know that patients with inflammatory bowel disease, unfortunately, have a high risk of needing surgical intervention. Tina just mentioned not too long ago that there are folks who actually also require colectomy, and there are salvage medications attempted to help them prevent surgery. At the same time, we also know that protein-calorie malnutrition has been associated with adverse outcomes postoperatively, even in the general population. And while that is actually an adverse outcome, we do know that patients with inflammatory bowel disease also have a high risk of protein-calorie malnutrition. So the aim of the study was to assess the impact of perioperative nutrition on the relative postoperative outcomes and complications. The data source included the nationwide readmissions database. ICD codes were used to identify the patients as well as the procedures. And postoperative outcomes included 30-day readmissions, infections, venous thrombosis, and as well as mortality. And the multivariable analyses tried to control for any potential confounders that would affect the outcomes. In terms of results, there were approximately 28,000 patients with inflammatory bowel disease who had concomitant protein-calorie malnutrition, who then also underwent intestinal resection surgery. About half of them had received nutrition support perioperatively, and for the most part, most of them actually had parenteral nutrition. And in about half of them, about 14,000 as well, were controls who did not receive nutrition support. When looking at the results, we find that nutrition support has been associated with a reduction in overall 30-day mortality. On the other hand, we also do find that nutrition support has been associated with an increased risk of overall infections, deep venous thrombosis, as well as central line infections. Now we say here that, on one hand, there is mortality benefit, but on the other hand, there's an increased risk of infections, and we suspect that this is due to the use of parenteral nutrition. There are strengths and limitations of the study. On one hand, it's actually a nationally representative cohort, so it's a very large sample size. Limitations, however, include that this is an observational study, and there was lack of granular data to look at protein-calorie malnutrition and its severity, as well as to control other potential confounders that could have driven the use of nutrition support. But all in all, we would conclude that perioperative nutrition support is associated with a reduction in 30-day mortality amongst patients with inflammatory bowel disease and protein-calorie malnutrition who undergo intestinal resection surgery, while taking into consideration the increased risk of infectious complications and deep venous thrombosis. Now, if we're to glean at least some clinical practice pearls from this, we would say that we should probably be vigilant about the patient's nutritional status when they are about to go to surgery, and we should focus on nutrition optimization as needed. We then move on to the next study. So this was done by Uma Mahadevan's group at UCSF, and they evaluated the use of corticosteroids and its impact on perinatal and maternal outcomes in patients with inflammatory bowel disease. As background, IBD flares are actually unfortunately common amongst pregnancy in about a third of these patients. And we also do know that active IBD is associated with certain complications such as spontaneous abortion, preterm birth, and infant infections. Fortunately, we have good medications to control for these flares, such as biologic therapies, thiopurines, and even combination therapies. And these have also been found to be relatively safe from the standpoint of maternal and infant outcomes in pregnancy. However, we also do know that a lot of our patients do express safety concerns of the continuation of these drugs during pregnancy, and a good number of them actually discontinue these medications during pregnancy. And so what happens when they flare, in this event? Corticosteroids are then used as rescue medications. Unfortunately, the impact of corticosteroids on maternal and infant outcomes are not yet very well described, and so that was the objective of this particular study. They used the Piano Registry, which is a large nationwide registry of patients who've provided self-reported outcomes at pregnancy with inflammatory bowel disease. And for this particular study, they looked at different maternal as well as fetal outcomes. So these included spontaneous abortions, preterm birth, intrauterine growth restriction, small for gestational age, low birth weight, cesarean section, and the need for the neonatal ICU during birth. They also looked at infant infections, developmental milestones, as well as congenital malformations. The study included about 1,500 patients. About a third of them, about 432, had mothers who were exposed to corticosteroids, and 1,000 of them had mothers who were not exposed to corticosteroids during pregnancy. And for those who actually had 1-year outcomes for their infants, that included about 1,010 patients. These are the baseline demographics of these patients, and their mothers. And when we look at the pregnancy-related complications, we see that in overall IBD patients, that exposure to corticosteroids are associated with preterm birth, low birth weight, as well as the need for the neonatal ICU at birth. And when you stratify it by Crohn's disease and ulcerative colitis, you see a divergence or differences in some of these outcomes, but for the most part, you can think of it as preterm birth, low birth weight, and the need for the NICU. Fortunately, there are no serious or non-serious infection risks increase in the exposure of corticosteroids. And when we look at developmental milestones, and we see here, the different rows showing 12 months, 24 months, 36 months, and 48 months for the infant, we find that for communication, fine motor, gross motor, as well as problem-solving metrics, that there was actually no difference in infants who were born to mothers who were or were not exposed to corticosteroids. However, at 12 months and 36 months, their scores for personal social development was actually lower in patients or in infants whose mothers were exposed to corticosteroids during pregnancy. When we look at congenital malformations, most of the congenital malformations actually occurred when steroid exposure occurred during preconception or the first trimester. And if you look at the bar graphs there, we actually find that orofacial clefts were more common amongst infants whose mothers were exposed to corticosteroids. But we also know that even for mothers who are exposed to corticosteroids without IBD. So that is not a surprising finding. There are strengths and limitations of this study. Strength, it being a large multi-center prospective cohort with longitudinal design. And limitations, however, include that these were self-reported participant responses. Corticosteroids were not very clearly characterized. And there were, unfortunately, a lack of control for several confounders in their multivariable analyses. But with that in mind, what can we glean from these data? So on one hand, in practice, we should make sure that patients or mothers or expectant mothers with inflammatory bowel disease are in stable remission and on appropriate IBD therapy prior to conception. And we do know that pregnant women with IBD may need corticosteroids, but be also at least aware that there are increased adverse events for both the mother and the child. So let's shift gears now to looking at the use of fecal calprotectin and its prognostic value in ulcerative colitis. And this was done by Bill Sanborn's group at UC San Diego. And by the way, just as a side note, I promise you I did not specifically bias my selection to UC-based studies. It was all actually independent of any institution. I just chose things that were actually interesting and also relevant to clinical practice. So that being said, the International Organization for the Study of Inflammatory Bowel Disease actually assembled a consensus group where they actually looked at treatment targets as well as the algorithms for treatment after the initiation of biologic therapy. And historically, they actually developed a consensus statement that you would actually follow these patients and try to assess for mucosal inflammation using endoscopy. A more recent update had actually now incorporated the use of fecal calprotectin as also another measure for inflammation status after initiation of biologic therapy. So the premise of this particular study was to evaluate the role of fecal calprotectin, not just for looking at disease activity, but also looking at its prognostic value after the initiation of biologic therapy in patients with ulcerative colitis. The study population that they used actually were obtained from the varsity trial. You may have recalled Tina mentioning earlier about the head-to-head trial of ustekinumab versus adalimumab, and the varsity trial actually preceded that, where it was a comparison between vedolizumab and adalimumab. Its historical footnote is that this is actually the first head-to-head biologic drug trial in IBD. So the study group actually took some data and did a post-hoc analysis of this clinical trial, and in particular, they were interested at looking at calprotectin when obtained at week 14, and looking at its cross-sectional value and at ascertaining endoscopic and histologic disease activity, while at the same time looking at the week 14 fecal calprotectin and evaluating its prognostic value and predicting what will happen down the road at week 52. And I list here the different outcomes that had used, be it symptomatic remission, clinical remission, endoscopic improvement or remission, histologic remission, and mucosal healing. This is the baseline demographics of the patients who were participating in the study. Not surprisingly, fecal calprotectin was elevated. They were, again, all having active disease prior to the initiation of biologic therapy. Now let's dig down into the data. So let me orient you to this colorful set of images. So the red dots actually represent fecal calprotectin when they assigned a threshold of about 100 micrograms per gram. And the blue dot actually represents the fecal calprotectin when they use a threshold of greater than 250 micrograms per gram. And if you look at the graph to the leftmost area, you see that this is actually the positive likelihood ratio when they actually looked at fecal calprotectin at different thresholds and its ability to determine moderate to severe endoscopic activity, active endoscopic disease, and histologic inflammation, either using the Robarts histologic index or the Capus grade. And then, of course, in the middle, you've got the negative likelihood ratio, and if you focus your attention to that on the right, it's their accuracy. And the accuracy was relatively between 68 to about 78%. So there was a modest ability for fecal calprotectin to, again, identify moderate to severe endoscopic activity, active endoscopic disease, as well as histologic inflammation. Now, what if we were to use this not to actually determine existing disease activity, but use it as a prognostic tool to predict disease activity at week 52? And in this case, they actually used a multivariable model, logistic regression. And again, you see here that fecal calprotectin, which is the blue dot, or I guess the cyan dot in this case, was associated with clinical remission, endoscopic improvement and remission, as well as histologic remission. The investigators then presented the data in a different manner, where they looked at week 14 fecal calprotectin and their levels and tried to relate that to endoscopic improvement or remission. So if you look to the graph to the left, the red bar actually represents those with endoscopic improvement, and the blue bar represents those without endoscopic improvement. And you see that those with endoscopic improvement had, numerically lower proportions of, or lower mean fecal calprotectin concentrations at week 14 and at week 52. And if you look to the right, you see the same trend or same pattern when you're looking at endoscopic remission as an outcome. So with these data, we conclude that fecal calprotectin at week 14 has a modest ability to detect current disease activity. And if you were to use a threshold of less than 250 per micrograms per gram at the week 14 dose, it does have some value at predicting whether the patient will ultimately have some disease response. So with that in mind, some clinical pearls that you can get from this study was that we should potentially integrate early fecal calprotectin monitoring within the treat-to-target algorithm in patients who initiate biologic therapy. And so let's now talk about nutrition and IBD. And this was a study not from the University of California this time, but from the University of Pennsylvania with Jim Lewis and his group. So this was actually a study that was funded by the PCORI group as well as the Crohn's Colitis Foundation, where they actually evaluated the use of Mediterranean diet versus specific carbohydrate diet for the induction of remission in Crohn's disease. And the question is that why this particular study? They actually gleaned this from their IBD Partners Forum, where there was keen interest amongst patients who expressed an interest in understanding the role of diet in the treatment of Crohn's disease. So the specific carbohydrate diet, as we know, has been used in time and over time for the treatment of inflammatory bowel disease, but the comparator group this time was a Mediterranean diet. And the reason they proposed of why they actually chose a Mediterranean diet is because in the general population, we do know that it's somewhat of that prototypical healthy diet, and there are some emerging, albeit observational data to show that those who actually consume a plant-based diet, such as the Mediterranean diet, have a lower incidence of Crohn's disease, and also reduce symptoms and improve quality of life. And so with their study design, this was a randomized study where they randomized patients with mild to moderate symptoms in Crohn's disease to either receiving specific carbohydrate diet or the Mediterranean diet. For the first 6 weeks, they actually provided the meals. So you see that scrumptious meal to the bottom left, and right in the bottom middle figure, you see a fridge full of their packaged meals. And then after 6 weeks, and then for the subsequent 6 weeks, they asked participants to actually purchase their own food. I guess they didn't have enough funding at the time. But with that, their primary outcomes were actually obtained at week 6, and then they also did additional secondary outcomes at week 12. Primary outcomes at week 6 included symptomatic remission, which they defined as a short CDAI score of less than 150 in the absence of any changes or initiation of medications. And their secondary outcomes included clinical remission, which was a CDAI score of less than 150, fecal calprotectin as well as CRP measures, and that is the reduction to less than 250 micrograms per gram for fecal calprotectin, or a greater than 50% reduction if their fecal calprotectin at baseline was over 250. And then for their CRP was a reduction to less than 5, or a greater than 50% reduction if at baseline their CRP was greater than 5. So in terms of their study, they actually randomized 197 patients to either the Mediterranean diet or the specific carbohydrate diet. I present you the medication characteristics for those patients. They're roughly similar between the two groups, as well as their baseline inflammatory activity. So let me point out that there was, interestingly, evidence of ongoing inflammation in about 42 to 52% of patients at baseline, which indicates that actually also half of the patients did not have evidence of ongoing inflammation. So that's a very interesting point because, as I mentioned earlier, the cohort that they recruited were those who actually had mild to moderate symptoms, but not necessarily using inflammatory activity as their recruitment or inclusion criterion. I will touch on that momentarily in one of their stratified analyses. And so let's look at the results. So if you look at symptomatic remission, clinical remission, fecal calprotectin response, or CRP response, there was actually no difference between the Mediterranean diet or the specific carbohydrate diet. Let's also key in on some pertinent pieces of information here. So on one hand, if you look at CRP response was actually quite low. It's about 3.6 to 5.4% of the individuals who participated in the study. And a fecal calprotectin response was also marginal, about 30 to 34%. But when we dig in a little bit deeper into the data and try to look at some of the details even further, if you look at the column for Mediterranean diet, we see here that at week 6, there was a statistically significant decrease in the symptom scores, an improvement in their SIBDQ, which is basically their quality of life measure, and a decrease in their fatigue scores, pain interference, sleep disturbance, as well as social isolation. And this was also similarly found in the column of individuals who actually received the specific carbohydrate diet. However, when they compared these changes between those who actually received the Mediterranean diet or the specific carbohydrate diet, we actually found that they were no different. And when they looked at week 12 outcomes, you see again a similar pattern as what was detected earlier. Now going back to what I mentioned about the baseline inflammation, Given that, there were some individuals who did have inflammation at baseline, some individuals who did not have inflammation at baseline, one could say that that was a potential confounder and could have actually influenced whether they would respond to the diet or not. So what they then did is they actually stratified analyses to actually include those with or without evidence of inflammation. And again, they found no difference in the response rates when they actually looked at the Mediterranean diet versus the specific carbohydrate diet. The investigators noted several limitations. So on one hand, both diets were notably healthier than what would be considered the standard American diet. They also brought up the questions about generalizability. So on one hand, they actually provided food for the first 6 weeks, which makes it actually highly tailored, and does that actually replicate real-life behavior? And then secondly, although I did not delve in too much into the demographics, they did note that there were mostly white females who participated in the study. And they also acknowledged the lack of endoscopic assessment of healing, and that primary outcome may have been too early at 6 weeks, but this was based on their patient recommendations. So in conclusion, we find that the specific carbohydrate diet was not superior to the Mediterranean diet for achieving symptomatic remission, and that fortunately, symptomatic remission was actually common with both diets. An interesting point is that because these are plant-based diets, there is actually a high fiber content, so there is actually increased consumption of fruits and vegetables. And so this goes against the dogma where you say you have to absolutely avoid fruits and vegetables in patients with Crohn's disease. But as I also mentioned earlier, normalization of CRP concentrations was unfortunately uncommon, with either of the diets. So what can we get out of this, and what is our take-home message? So we can say that, that the Mediterranean diet is actually relatively equivalent to the specific carbohydrate diet for benefiting symptoms and inflammation in patients with Crohn's disease. And why is that relevant? Because the specific carbohydrate diet, by the way, is actually relatively difficult to follow. And it also requires a lot of hand-holding, as well as optimizing, and also discipline to be able to follow. So this then actually provides some data to show that maybe something which is simpler, which is more liberal, and which is more generally known, the Mediterranean diet, is an acceptable substitute. To my chagrin or disappointment, unfortunately, it shows that the Mediterranean diet nor the specific carbohydrate diet were not useful by themselves as monotherapy for induction or remission. However, there is still a role for its use as an adjunctive therapy, in addition to whatever pharmacologic agents we have in our arsenal. So in brief, we chatted very briefly about, perioperative nutrition and the importance of nutrition optimization prior to surgery, the importance of trying to make sure mothers or expectant mothers have their disease under control prior to pregnancy, and balancing that out with the use of corticosteroids. And we see the prognostic value of calprotectin. And with this DINE-CD study, the Mediterranean diet was found to be equivalent to a specific carbohydrate diet. So, thank you very much for your time.
Thank you. Thank you